was built on mechanical properties. So we would cut the tooth down all the way around it so that we had retention and resistance. Today, we rely more on adhesion and the glue. And I think that our techniques and technology have improved so that we can do that and retain teeth longer. In 2024, it took me 3 years to get through the Coy Center comprehensive curriculum program. It's over 300 hours at a comprehensive teaching center that's dedicated to advancing dentistry through science. I think that this program has probably changed the way that I practice, and it's one of the best things that I've ever done in my career. Uh, I'm currently finishing a fellowship in clear aligner therapy. A lot of the patients that I see that need restorative dentistry would also benefit from having the teeth in a better position. And rather than working with other specialists, I like to have my hands in both parts so that I know what I'm getting and what I'm starting with. Along with that, I've taken various other courses focused on aesthetics. Dr. Otten built the practice dealing with TMJ disorders, so we see a lot of those. Veneer cases, full mouth rehabilitations, advanced adhesive dentistry, other courses on clear aligners, and dental photography is also one of my passions. My hobbies. There's really just one of them. This is my girlfriend Anna. She's a dentist in Knoxville, Tennessee. So we enjoy traveling to learn new things together. But we also just enjoy traveling to travel. Um, this weekend is actually our 1 year of anniversary of dating. So dating long distance is a challenge if anyone's ever done it. But we made it a year, so I guess that's something to be proud of. So an overview of what we're going to talk about, we're going to talk about tooth wear, and we're going to talk about physiologic tooth wear, meaning the natural and expected wearing down of tooth structure over time due to chewing, swallowing, speaking, and breathing. The questions that a lot of patients ask is, what is normal, and is tooth wear normal? And if it is, how much should I expect to see? On the other side of the coin, there's pathologic tooth wear. So pathologic tooth wear is the loss of tooth structure that's excessive for a person's age, and that detrimental amount of tooth wear can cause functional, aesthetic, or sensitivity issues. So the questions that go along with that are, what are the causes of it? How do we identify it? What are the symptoms to look for? And what can we do about it? Trying to see if I can move the OK off of my screen where it says the meeting has been recorded, but I don't know that I can. I think I can still see my screen well
Okay,
enough.
sorry
I've
about that.
done it enough that I think I can figure it out.
Okay. I'm not,
Uh,
we're not seeing it on our screen, I guess, but
oh, perfect.
that's hard for you.
No problem.
Okay.
So, physiologic tooth wear. So, what is normal? And according to the literature, it's normal to lose around 10 microns of tooth structure per year. So, this literature comes from orthodontists that can follow patients from 6 years up until 70, 80 years and get models and compare the different amount of tooth wear. So, if we lose 10 microns of tooth structure a year, that means that we should lose about 1 millimeter of tooth structure in our lifetime if we equate that to a 90-year-old individual. And the way that I look at that is the thickness of the biting edge or the tearing edge of the front tooth is about 1.5 to 2 millimeters thick. So I know that if we see the inner part of the tooth structure, that means that we've already had pathologic wear throughout our lifetime. So I have a couple pictures. The picture on the upper right is a 17-year-old female. You can see she doesn't have any wear on the edges of her teeth. And the picture on the lower is a 43-year-old male. You can see where he has worn through the outer part of the tooth. He's into the inner part of the tooth. And he has a lot of bite issues and frankly, a lot of pain associated with some of the things. The picture on the left that I want to point out, that white outer structure, I like to think of teeth kind of like an M&M. So they have a soft, they have a hard outer structure and a soft candy center. And the white that you see in that X-ray is kind of that hard outer shell, and the inside that you see is that soft candy center. So the outside is called enamel, and the inside is called dentin. So other than tooth wear, what else is normal? What else should we see in our teeth as we age? A lot of patients present to me with crowding of their lower front teeth, and they say, doc, is this normal? And surprisingly, it is. And what happens is here's our lower teeth. And as we chew, our teeth are constantly moving up and down. And so we're wearing these side surfaces of the teeth until the teeth start to slip past one another. So crowding steadily increases from when we get our adult teeth up until about age 60. It's more often seen on the lower teeth and it's more prevalent in females. So then people ask me, should I fix my crowding? And the problem with crowding is it's harder to maintain the teeth, it's harder to take care of the teeth, it's harder to clean the teeth. As we age, we don't have as great of dexterity and we can't do some of the things that we used to do when we were 20, 30 years old. And we see that a lot in patients' limitations to maintain and clean their teeth. So I do think that crowding allows those teeth to harbor bacteria that cause inflammation. We all know that we don't want inflammation in our body. If we think about where our teeth are, they're about 4 inches from our brain and about 6 inches from our heart. So it's naive to think that the bacteria and inflammation happening in our mouth is not causing issues other places in our body. So other things that we notice a lot are in this picture, those on the right side are implants, and those are implant crowns. So implants are essentially screws that are put into the bone, and then we have crowns that are screwed into those. The problem with implants is they're stationary. So as we have these teeth that are moving constantly in this ligament, and our teeth are crowding over time, we end up developing a space on the front side of that implant crown. So that becomes a place that we trap food, trap bacteria, and we're unable to maintain. So this is actually a patient from my office, but you can see the decay that's starting on the distal aspect or the back aspect of that premolar. And those are really challenging to fix because there's not a lot of space and they're usually quite deep. So what's not normal? When we see spacing, that's not normal. Spacing is usually signs that there's some sort of issue with tongue function, or there's a tongue thrust, or there may be issues with sleep apnea. So those are things that we try to dive into a little bit deeper, but we do tell our patients that, these aren't normal. So on the other side of the coin is pathologic tooth wear. And again, that's tooth wear associated and considered when it occurs at a greater extent than would be normally expected given a patient's age. So that occurs due to four different factors: attrition, abfraction, abrasion, and erosion. And we'll go through those each in a little bit more detail. So the first one is attrition. And attrition is normal mechanical wear resulting from mastication limited to the contacting surfaces of the teeth. So it's when the teeth grind against each other when we're chewing. So things that affect that are the diet. Everything that we eat is acidic, and the acid starts to break down our teeth or starts to soften that outer part of the tooth. So when we have that softening from the acid and then we're grinding on the teeth, we lose more tooth structure than if we didn't have such an acidic diet. Another one is the chewing pattern. So I'm going to play a couple videos for you. So notice that this patient, when they chew, they mainly go up and down. You don't see a lot of them coming from the outsides of their teeth, rubbing in, and you don't see a lot of places that would form wear on the teeth. And compare that to this person who really gets on their teeth when they chew. And they're going to cause a lot more wear, have a lot more issues just by the chewing pattern. So reasons that we think that people have these larger envelopes or wider chewing patterns is that they don't have great stability with their back teeth. So they're constantly trying to find that stability, and it leads to them having this wider envelope when they chew. Another one is bite force. If you see someone who has really large masseter cheek muscles, those people tend to be able to put more force on their teeth. and that can be more devastating with the wear that they can cause. Another big one that's not talked about enough, I don't think, is opposing surface or materials. So the picture on the right is a patient who had 4 porcelain crowns placed. And the problem with those porcelain crowns is if they're in that chewing envelope or that chewing pattern, the porcelain on the back of those crowns is very porous and very rough. And so it's like sandpaper grinding against their natural teeth. And that picture below is what that patient's lower teeth look like when they separate. Another one is salivary flow. When I think of salivary flow, I think about my arm. And if I were to itch my arm, I might get a red spot, something like that. Imagine if I had dry and flaky skin and I itched my arm. Now I'm more likely to get bleeding. I'm going to cause more destruction. Same thing with the mouth. If things are not properly lubricated and the saliva is not able to coat and protect the teeth, we're going to get more destruction. So another one that I don't think is talked about enough with attrition, and it's something that I see a lot with TMJ disorders, um, is the inclination of the front teeth. I think that a normal inclination of the front teeth is like this, but when the front teeth are really tight, it doesn't allow you to chew. It doesn't allow that lower jaw to move. So I'm going to play a couple videos here for you. So this is normal. You open, you come forward when you chew, and you go back. I'm going to try to play that one more time so you can see it. And now look what happens when we change the inclination of those teeth. So those teeth are tipped back. So now as we come forward, we don't have any room. So now we're going to start to wear on the teeth. I'm going to play that one more time. Imagine that upper tooth is a porcelain crown that's porous and rough. What do you think is going to wear? The lower front tooth. So another one a lot of people talk about is bruxism or sleep bruxism. And I think that it has gotten a bad name over the years. I think 20 years ago, everyone was told that they were bruxing and they got a night guard from their dentist. If you saw wear on your teeth, your dentist said, well, you grind your teeth at night, here's a night guard. And I talk to a lot of patients and they say, oh, I grind my teeth at night. And I say, how do you know? And their response is usually, oh, my dentist told me. Unfortunately for me, that's not a good enough reason. Um, I don't think that we do nearly the destruction to our teeth at night that we once thought we did. And kind of the light bulb moment for me was I don't get a lot of patients calling me, telling me I broke my crown in the middle of the night. I woke up with porcelain chunks in my mouth. I broke my tooth while I was sleeping. 99.9% of the emergency calls I get are saying I was eating, I was chewing, and I think that we do a lot more destruction when we go through these functional movements if the teeth aren't in the right place than we once previously thought we did. Current science suggests that only about 8% of the population actually struggle with true sleep bruxism. And with those patients, we make a night guard, and you can see on the night guard, they have streaks because they're moving side to side. They're not moving front to back. Another theory why people grind is that they have an imbalance in their bite. A mosquito bite is an irritant. So you can have an irritant with the way your teeth fit together. So with a mosquito bite, you're itching it or scratching it. Same thing, you're grinding down that irritant. Your body is trying to get rid of that irritant um, to give you more of a happy, comfortable resting place for your teeth. So when I see patients that have issues with their bite, they notice that they're wearing down their teeth. The first thing that I do is I usually put them in something called a deprogrammer. And the deprogrammer, all it does is simply separate the teeth. And the question is, with your teeth not touching, do you feel better? Because if you feel better and we can take away the problem that you're experiencing, then we know that the problem is the way the teeth fit together. And maybe we just need to put the teeth together in a better way. Again, if patients are still grinding on the deprogrammer, that's when we make them a night guard because we know that that grinding is not coming from the way the teeth fit together, but it's coming from a part of the brain. And you guys have probably had the right doctor on here to fix the brain, but I am not that guy. So the next one is abfraction or non-carious cervical lesions. And there's not a lot of people don't tend to agree on what causes this or what it's caused by. Um, but it's the pathological loss of hard tooth substance caused by biomechanical loading forces. It's thought to be a result of flexure and chemical fatigue degradation of the enamel dentin. So what they're saying is they're saying it has to be multifactorial. There's a lot of different factors at play. One of them is the acid in the diet. So again, we're softening that tooth structure when we're chewing, when we're eating, when we're drinking pop, when we're, doing different things like that. The next is friction. If your teeth aren't lined up exactly up and down, then the force that you distribute doesn't go down the long axis of the tooth and may be off at an angle. So that's allowing that tooth to bend and flex. And the third one is cyclic fatigue. So when we chew, we don't just bite up and down. We have these cycles of chewing and we go through multiple cycles each time that we eat, and we eat multiple times a day. So over time, that causes a lot of stress and fatigue on the teeth. So what these show up as is these notches um, around the root surface of the tooth or the cervical aspect of the tooth. The patient on the left is a patient that is in my practice, and the one on the right I thought was just a great video, or a great photo to illustrate that. So the next one to talk about is abrasion. And abrasion is an abnormal wearing away of the tooth substance caused by causes other than mastication. So how else could we wear away our teeth? And we have physical wear that's caused by materials other than the way the teeth fit together. A big one is toothpaste. People don't understand how abrasive toothpaste can be, and I'll get into that a little bit on the next slide. The other one is tongue and cheeks. So when we have an acid challenge to our mouth and we're constantly rubbing our tongue over, let's say, the back of our front teeth, we're wearing away more tooth structure because we have friction combined with the acid. So RDA value is relative dentin abrasivity. And I have sent Kathleen 3 documents that she is going to send you guys. One talks about the relative dentin abrasivity of the most common types of toothpaste. For my patients, I try to keep them under a 70 RDA. Under 100 is what's recommended. Um, the second document that I have is it talks about the pH of mouth rinses. And when we go through pH, you'll see that a little bit more. And then the third document is going to be about dry mouth and xerostomia and ways to combat that or different types of treatments that you can try. So RDA, basically a more abrasive toothpaste leads to a greater loss of tooth structure. If you have, just like a drier mouth, if you have something that's more abrasive, it's going to lead to more destruction. So I try to tell my patients to avoid whitening toothpaste because those are very, very abrasive. And I also want my patients to choose a soft or ultra soft toothbrush. The picture on the left is the Nimbus toothbrush. It's my favorite toothbrush. That's the one I give out at my practice. I looked at some other ones. There's a Colgate 360-degree ultra soft sensitive toothbrush. And then my periodontist who deals with gum and bone every day, he recommended this gum care one. So this study on the left side of the screen, they took extracted teeth, and you can see the teeth kind of in this middle photo right here. And they did 150,000 cycles of brushing with different things. So on the very left side is after 150,000 cycles, on the left top, excuse me, is after brushing with water. So non-abrasive water. And you can see you don't have a lot of wear on the teeth. The one below that is brushing with a non-abrasive toothpaste. The third one is brushing with Crest Oral Pro Health or something that's very abrasive, a whitening toothpaste, things like that. So imagine how many times in your lifetime you brush your teeth. Um, that's the devastation that can be caused by using the wrong toothpaste. Saliva plays a huge role in this. So saliva is a lubricant for speech. It helps to clean and form a protective layer around the teeth. Whenever you get food stuck in between your teeth, you're constantly trying to get your tongue in there, trying to get some saliva in between there to dislodge that piece of food. That's what it does. It also mixes with the food, and facilitates proper digestion and swallowing. We'll get into pH a little bit more, but it helps to remineralize and buffer against acids from food. So the salivary pH is 6.5 to 7. 7 is a neutral pH, which is something similar to water. It also acts as an immunological barrier to protect tissues from bacteria, viruses, and fungi. Uh, I was reading the research about that, and it's amazing how many of those we flush out every single day in our saliva. It's a clear liquid. It's composed of mucins, electrolytes, immunoglobulins, proteins, and enzymes. The big proteins in saliva are calcium and phosphate. Those are what are needed to strengthen the tooth. Those are the proteins or minerals that acids take away from the tooth. So saliva is trying to reinforce that. Really, what it does though is it maintains the environment. So it keeps the symbiosis. If it's reduced, then we tend to trend towards an acidic environment, which allows acidic bacteria to flourish. Those are the types of bacteria that cause a lot of cavities. So, what I see in my aging population of patients is if they have problems with dry mouth, they tend to get a lot of cavities. They tend to get a lot of root cavities. So xerostomia. Xerostomia simply means the sensation of a dry mouth caused by the reduced production of saliva. And about 40% of drugs, or over 80% of the most commonly prescribed medications, which is over 400 medications, have an adverse effect on salivary production, which is a huge number. And I think in medicine today, more than any time, we're giving people a lot of medications. We're solving problems with medications. Um, Sometimes I don't think we're looking at root causes because a lot of those practitioners don't have the time. You know, they're seeing so many patients every single day and they get about 5 to 10 minutes with each patient. Um, and I think that our medical model is going towards giving out more medications. About 33% of dry mouth is attributed to disease, whether it's Sjogren's syndrome. Other immunocompromised patients tend to have a drier mouth. It affects around 30% of the population over 65. It's a big side effect of radiotherapy for head and neck cancer patients. If you have radiation to the neck area, it affects your salivary glands big time. And that low salivary flow leads to increased risk for dental cavities. Some of the signs and symptoms are bad breath, cracked lips, fissured tongue, ropey, thick saliva. And what a lot of my patients tell me is I can't drink enough water. I keep water by my bed. I have water everywhere I go, and I'm still constantly dry. So something that I tell my patients about is xylitol. And xylitol is a naturally occurring plant-based sugar that bacteria are unable to use to proliferate, which starves and kills them. Um, Basically, when we eat food, bacteria breaks down the sugar that's in the food into acid, and that's what it uses to feed itself and attack our tooth. So this sugar, bacteria is not able to break this down into acid, so it can't proliferate and it starves the bacteria. So with xylitol, you should take 6 to 10 grams per day, spread out in 3 to 5 doses. Each serving should be consumed for about 3 to 5 minutes. So whether it's a mint, whether it's gum, you should be chewing or having that mint for a little bit of time. Children only need 5 grams per day, and again, that should be spread out in the 3 to 5 doses. The one thing to note with xylitol is it's toxic to dogs. They also cannot break it down. So they are unable to process this sugar. Um, I have a whole handout for you that Kathleen's going to give you, but some of my favorites are these Spry Dental Mints. This is the toothpaste that I recommend for 85 to 90% of my patients. It does have a fluoride-free option if that's something that you want. And then there's these Xylamelts. These actually stick on the roof of your mouth and help to produce saliva for you. So the next cause of pathologic wear is erosion. And erosion is chemical damage, mostly demineralization by acids other than those produced by the bacteria. And there's two types of erosion. There's extrinsic erosion, which is things that we're putting into our body, and then there's intrinsic erosion, which is things that our body produces. So the first is extrinsic erosion, and a lot of the acid that we put into our body comes from our diet. So the first thing to look at is the pH scale, and pH is the potential of hydrogen. It tells how acidic or how basic something is. For an example, water is neutral. Something that I didn't know about the pH scale for a long time is it's a logarithmic measurement, meaning that a 7 is neutral. When you get to a 6, you're 10 times more acidic. If you get down to a 5, you're 100 times more acidic. When you get to a 4, you're 1,000 times more acidic than water. Orange juice, for instance, is a 4 on the pH scale. The outer layer of tooth structure, the enamel, that outer layer of our M&M, the strong outer layer, starts to dissolve at a pH of 5.5. The inner layer of tooth structure, or dentin, starts to dissolve at a pH of 6.5. So when that outer layer is gone, it's much easier for that inner layer to dissolve. One thing, I'm not pro or against fluoride, but one thing that fluoride does do is it remineralizes the outer part of the tooth and it allows it not to dissolve until a pH of 4.5. So it does make the outside of the tooth 10 times stronger. In my opinion, I think erosion is probably the most important cause of tooth wear, and it's becoming more prevalent worldwide. I talk to a lot of patients every day, and people drink Diet Coke, Dr. Pepper. Well, soft drinks, Coca-Cola is a 2.7 on the pH scale. A lot of kids these days are drinking a lot of sports drinks, Gatorade. That's a 3.0 on the scale. A lot of people are drinking energy drinks to get through the day. Red Bull, 3.4. And then fruit juices, we talked about it. Orange juice is a 4.0. The one thing to note with fruit juices, they've done research and there are now calcium fortified fruit juices. And if you use those do not cause nearly as much tooth breakdown as regular fruit juice. So one of the worst acids that you can use is citric acid, and it's found in almost every soft drink. And the really devastating part about citric acid is it binds to the calcium in your tooth. So not only is it breaking down and softening the tooth structure, but it's leaching the calcium out of the tooth, causing to an increased breakdown. With pop or with juice or with energy drinks, whatever it may be, the exposure time is really, really important. So people that are sipping those drinks over a period of an hour versus drinking it in 20 minutes, they're exposing their body or their mouth to a lot more acid. So it takes around 20 minutes for your body to recover from an acidic challenge. And so if you don't allow that 20-minute buffer and you just continually challenge this system, it's going to lead to breakdown. So sipping, swishing, holding that drink in your mouth is certainly not recommended. Things that you can do is you can drink them through a straw. That has less of a negative impact on your teeth. Other things, as I was doing research for this presentation, are medications. Aspirin tablets are acidic, and asthma inhalers. There are spacers that you can buy for asthma inhalers so that you don't get the medication directly on the teeth. It also said regular intake of chewable vitamin C or effervescent tablets can be an issue. The pictures that I'm showing are maybe of a mid 40-year-old, 40-year-old woman in my practice. And she came, and clearly there's a lot of issues. And when I look at the back of her front teeth on that picture on the right, she has some acid challenges happening. So we start to have a conversation about diet. And she eats a pretty healthy diet. She doesn't eat a lot of fruit, nothing that really jumped out to me. So I said, okay, tell me what you drink throughout the day. And she said, well, I start my morning with a couple cups of coffee, and then I switch to Dr. Pepper. And I said, okay, tell me how you drink the Dr. Pepper. She said, well, I kind of sip on it throughout the day. And I said, how many Dr. Peppers do you have per day? She said, well, I wait until it gets warm, and then I walk over to the refrigerator and I get a cold one and I open it and I sip on those throughout the day. And I said, how many do you open per day? And she said, somewhere between 4 and 6. And I will tell you that that has created enough devastation that either this patient will lose all their teeth or they will have to pay for a full mouth rehabilitation. Um, and I think it's things that can be avoided with diet counseling early. So I put this slide up just so you can see common pH values of things that we eat every day. One to note is water. You know, you go to a restaurant and you order water, no problem. Water is a 7 on the pH scale. But the minute you put a lemon in it or you suck on that lemon, now you're introducing an acid that can be damaging to your teeth. So the one that I don't agree with completely on this is coffee on the left side. I think that if you're drinking black coffee, it's somewhere between a 5.5 and 7. Coffee with a lot of sugar, a lot of sweetener is going to be more acidic. You can see wine on the list is between 2.3 and 3.8. Again, your teeth start to dissolve at a pH of 5.5. Coke, there's the 2.7. You know, a lot of fruit, if people eat more than the average amount of fruit, then that can cause issues. Lemons, limes, and juice, 1.8 to 2.4. Those are a pretty big one. And a lot of people use like a vinegar dressing, and they don't understand. A lot of people eat a lot of salads and have vinegar on it. That can really lead to a lot of tooth wear. So outside of the diet, the other part of environment that I think everyone should at least be aware of, because when I learned about this, it kind of blew my mind. When this lady saw her dentist 2 weeks before these pictures were taken, she had no spaces in between her teeth. She had beautiful teeth. She had some restorations done. You can see the silver fillings in the top left photo, but she didn't have the gaps in between. She went to the Dominican Republic for 2 weeks, and she's a swimmer. She swam in the resort pool maybe close to 2 hours a day, is what the report said, which is a lot of swimming. I understand that. The problem was the pool wasn't properly chlorinated, and that chlorine was so acidic that it ate through her teeth. And she ended up suing that resort, and they ended up paying for her full mouth rehabilitation because their pool wasn't properly chlorinated. But, you know, for parents with kids on the swim team, I think that knowing if your pool is properly chlorinated and being able to check it is an important thing. So on the other side of erosion is the intrinsic erosion, and that's the acid that we produce within our body. So the first one is gastroesophageal reflux disease. So that's regurgitation of the stomach acid into the esophagus approximately 2 hours after consumption or after eating a meal. And that typically shows up as heartburn. It's more common with chronic alcoholism. It can be drug induced. Obesity plays a factor in it. Patients who smoke are more likely to get it. And it can be diet dependent. You know, you hear people say all the time, oh, I can't eat spicy foods because it gives me heartburn. And the nice thing with gastroesophageal reflux disease is it's happening 2 hours after digestion. So at the time of digestion, the acidic level of your stomach acid is much more acidic than it is 2 hours after. After it's had a chance to mix with the food, that food buffers it a little bit. So a pH of 3 to 4, yes, it's still acidic, but it could be a lot worse. Silent GERD is one that's not talked about enough. It's laryngopharyngeal reflux disease, and it doesn't present as your typical heartburn problems. People say they have a frequent need to clear their throat, or they feel like they're choking. They have a chronic cough or hoarseness in their mouth, a sour acidic taste, or a recurrent sore throat. So, as we increase acidity in our gut, we induce our cheek muscles or our masseter muscles to start firing, and they fire involuntarily. And that's called RMMA activity, so rhythmic masseter muscle activity. So that's associated with sleep apnea because patients have these mini episodes of RMMA activity, which means they're decreasing their rest and digest system, they're increasing their fight or flight system, which leads to a microarousal in their sleep. So they're not getting into these deep stages of sleep and are constantly essentially running halfway around a track and then running back. And they're not ever getting into that deeper stage of sleep throughout the night. So a lot of people will wake up not feeling refreshed and not feeling like they got good quality sleep. It can be related to posture. We saw a large outburst of this during COVID when people were sitting at home working on their computers all day. If it's suspected in my patients, I try to have them see a gastroenterologist. I try to get an upper scope done. 24-hour pH monitoring is also an option. There's also a test for $150 that you can do online. It's called pepsincheck.com. Pepsin is an enzyme that comes from the stomach acid, and when it's found in the saliva, it tells you that there's more acid in the oral cavity than there should be. So this is a patient in my practice, and this just shows what gastroesophageal reflux disease can do. He has worn down his teeth. He's certainly exposed the inner part of the tooth, and he's got a lot of breakdown in tooth structure. And I've had numerous conversations with this patient. He doesn't want to do anything, and I can respect that idea. I just told him, you're probably looking at losing all of your teeth at some point. So the other part of intrinsic erosion are the eating disorders. So we have anorexia, which is characterized by food restriction, body disturbance images, and restricted food intake. These are the really thin individuals that are essentially starving themselves. They're just not eating. On the other side of that is bulimia nervosa. So bulimia is the eating disorder marked by a cycle of binge eating and then some sort of compensatory behavior trying to prevent the weight gain. So in that binge purge cycle, usually the purge is vomiting. Sometimes it can be excessive exercise or fasting. Those patients usually present as normal or slightly overweight. And the problem with the constant purging is it creates a lot of health effects later in life, from electrolyte imbalances, GI problems, dental erosion, and heart complications because that acid coming up through the body um, hurts a lot of different systems. And the reason it does that is when that acid comes up, it's at a pH of about 1 right after we eat. So if you think of water at a 7, a pH of 1 is a million times more acidic than water. And that's what they're putting in their mouth every time that they vomit. So it is really, really devastating to teeth. Usually what we see is it affects the upper teeth. The lower teeth are typically protected by the tongue. And certain drugs, cancer drugs, can lead to increased vomiting. So that's something that we're very aware of with those patients. So what can you do after vomiting occurs? The worst thing you can do is brush your teeth. You just had an acid sitting on the teeth. It's softening the teeth, especially if you have an abrasive toothpaste and toothbrush, you're going to increase the wear that's going to occur. So the best thing that I found in the research is actually to take a Tums or an antacid tablet. That will help to rapidly increase the pH and start to balance things out. Another thing you can do is add 1 teaspoon of baking soda with 8 ounces of water, swish that in your mouth for 30 to 60 seconds and spit that out. A third one that I recommend for my patients is this basic mouth rinse called CTX4. It has a pH of 10, so it does a really nice job of balancing out that pH quickly. If you don't have any of those, you can drink milk, eat food like cheese or sugar-free yogurt. And if none of those are available, you can rinse your mouth with water. But the big takeaway is wait to brush till at least 30 minutes and then use a soft toothbrush and ideally a fluoride-containing toothpaste because it's going to strengthen that outer layer of tooth structure. So what to do if you notice any of these signs, symptoms, notice that you have problems with your teeth getting shorter, thinner, more worn, or you have an issue with your bite. First thing to do is talk to your dentist. They should be the knowledge base for you or the, I guess the professional that should be able to provide you some guidance. All of my patients get a thorough medical and dental history. Most of them ask me why they have to fill this out. And I think at this point in our lives, it's naive to think that the mouth isn't just a gateway into the body. I think that what's happening in the mouth is affecting other things. And I hope I showed you in this presentation how much the different medications that you may be taking may affect what's happening in your mouth. Your dentist may want to take study models, they may take x-rays, they may take photographs. They're going to try to determine first and foremost, is this something that's actively happening to you, or is this something that's happened in the past? I try to evaluate my patients in four main areas. I look at the gum and bone supporting the teeth. I look at the bite. I look at the way the teeth are functioning and the way the teeth fit together. I look at teeth in general. So I look for old fillings. I look for decay. I look for cracked teeth. Cracked teeth is a big one that we see almost on a daily basis. And then I look at their smile. And for the smile, it's really, is the patient happy with how things look? Again, if I have a patient that is having some of these concerns or some of these issues, typically the first thing that I try is I use a deprogrammer. And that deprogrammer does nothing more than separate their teeth. And my question is, with your teeth apart, can we improve the way you're feeling? And if it is, then there's a way to fix you. We just have to get the teeth to fit together in a better way for you. Treatment is guided towards restoring function, replacing tooth structure that's been destroyed due to disease. I want to thank everyone for your kind attention. I really appreciate you guys letting me come on. I hope I was able to teach you something that maybe you didn't know. And with that, I'll open it up to any questions.
Great. Do you have a question? You can either unmute yourself or stick it in the chat, which is the little bubble, at least at the bottom of my page. Um, I guess one question I had is how often should older adults have dental checkups to monitor tooth wear? What do you recommend there?
Yeah, I think that's a great question. What I typically recommend is you start with every 6 months. And at my practice, we are really fastidious about checking the gum and bone health because if that goes away, that's when you start to lose teeth. That's when teeth start to become loose. So we look at the probing depths or the gum health measurements around each tooth every 6 months to a year. And if those numbers are increasing or you're getting a lot of bleeding, then we know that there's active inflammation. And some of my older patients, I will recommend that they see us, every 4 months or every 3 months. It's not that much more of a cost to save your teeth,
Yeah, it's a preventative measure.
right?
Another question that came in is why does sleep apnea cause tooth spacing?
Yeah. So I think it goes back to the idea, the book I think is called A Tiger in the Cage. And essentially, your tongue is the tiger, and the cage is your mouth, and the cage is too small. So we have in today's world and for today's young kids, we're doing a lot of expansion and we're doing a lot of building of their airway and trying to create enough room for their tongue and also get their tongue in the right position. But people that didn't have that when they were growing up, their tongue is constantly trying to find a place to go. And I see it all the time. Patients have a tongue that is essentially too large for their mouth. And so it's going to constantly put pressure against those teeth, creating that space.
So another one, do you recommend brushing with baking soda?
It's a great question. I had a patient ask me this today, actually, and I would say that I don't have a great answer. I'm happy to look it up and give Kathleen that answer to answer that question. I know that baking soda is basic and it certainly helps with the acid part of it. I know that there's something to the whitening effect of baking soda as well. But for a normal everyday toothpaste, I can't speak to its efficacy.
Okay. Do you do root canals and crowns?
Yeah, so I don't do the root canals, and the reason is I think that the root canals need to be done under a microscope.
Mhm.
And the only people that have microscopes that I'm aware of in Lawrence are the endodontists. Lawrence Endodontics is where I refer my patients to. I think that they do a nice job. Going back to my initial slides, I used to work for corporate dentistry,
Mhm.
and we did everything there. And I thought that I did a pretty good root canal. Um, but it took me about 2.5 hours to do a molar root canal, and it takes my endodontist 45 minutes to an hour. So, what's more comfortable for my patient? And it's just what the right thing is for the patient. Crowns, absolutely. I try to stay away from doing full coverage crowns. I try to take away as little tooth structure as I possibly can. A traditional crown essentially was prepared to the gum line all the way around the tooth. I don't think that we need to take away that much tooth structure. I don't think that we need those mechanical principles anymore. Um, and I think that they cause more catastrophic failures long term.
Hmm. So I don't know if you know the answer to this one, but is the chlorine in the Lawrence pools at the proper level? Or how do you find that out? What's proper?
I believe that proper from the article was somewhere between 6.5 and 7.
Okay.
Um, and if you Google probably case study about chlorinated pool water, it talks about how they should be properly chlorinating it.
Mhm.
Um, I have to assume that the Lawrence pool water is at the proper chlorination, but I have no idea.
Okay. Here's another one on my list. So what causes tooth sensitivity and what can be done about it?
Yeah, so tooth sensitivity can be caused by, again, it's multifactorial. If you have a bite where you're having bending and flexing and you're not putting the forces down the long axis of the tooth, that can lead to um, recession of the gums, and that exposes the root of the tooth. That root of the tooth isn't supposed to be exposed, so it can absolutely be sensitive. It has tubules that run from the nerve of the tooth to the outside. So what can be done for it is you can use some sort of desensitizer to try to block those tubules. The toothpaste that I shared, that that Progel 5000, that is my favorite toothpaste for sensitivity as well. My girlfriend has extremely sensitive teeth. She's one of those people that if ice cream touches her teeth, she doesn't like it. And she's tried a lot of toothpaste, and she told me the other day that this Progel 5000 is the only one that's really improved her sensitivity.
So what about good gum health, things like that? Is using like a water pick helpful to overall
Absolutely.
hygiene?
I think that a toothbrush and floss are the number one and number two.
Mhm.
I think that if you're not going to use floss, which a lot of people just tell me flat out, I'm not going to floss. Okay. We have to use some sort of interdental aid. I think that a water pick is great. I actually recommend a lot of my patients add a diluted amount of bleach to their water pick because
Mm,
now they're not only cleaning, but they're disinfecting. The way it was told to me once was, let's say you're out in the garden and someone offers you a piece of pizza.
mhm.
You have two options. You can use the garden hose and you can rinse off your hands and then you can eat that piece of pizza, or you can walk inside and wash with soap and water and then eat that piece of pizza. Same thing with your teeth. Are we just blasting it with water or are we trying to clean and disinfect? I recommend a water pick daily though. I think that water picks are a great adjunct, especially as we start to lose dexterity.
So how do you determine like what the proper amount of diluted bleach to stick in there is? I mean,
Yeah, I have a sheet that I can send that to you too, Kathleen, and you can send that
okay.
out. I believe that it depends if the bleach is 8% concentration or 5% concentration.
Okay.
I believe with the 8% concentration, it's a half teaspoon to 16 ounces of water. And I think
Mhm.
for the 5%, it's a full teaspoon to 16 ounces of water.
Okay. Interesting. I'd never heard that before.
And it will taste a little bit like bleach,
Hmm.
but just know that it's doing a good job for you.
Okay. Anybody else have questions? We've got a few more minutes. If um, this this is another. Oops, hang on just a second. I found it here. Got another question.
Perfect.
Um, I had a real problem with the lining of my cheeks peeling off. The doctor said, ask the dentist. The dentist said, uh, quit sugar candy and toothpaste, and it worked. Did I just present that correctly?
Yeah.
Okay.
So typically in a lot of toothpaste, there's an ingredient called SLS, which is sodium lauryl sulfate, and that is usually the cause of it. So what we have is we have patients switch their toothpaste to a non-SLS toothpaste, and it tends to take care of it.
Hmm.
And I don't know. I don't know the exact mechanics as to why the SLS interacts with the soft tissues in that way, but we tend to see a lot of tissue sloughing with patients on an SLS toothpaste.
Okay. Another baking soda question, is it too abrasive to brush with?
And that would be my question. That's what
Yeah.
I don't know. I would think that it wouldn't be great to brush with it every day, all the time. I think, like anything, everything in moderation is probably okay. Um, but I think that if it was supposed to be a toothpaste, someone would be selling it as a legitimate toothpaste.
Yeah.
I know that, Arm& and Hammer makes a lot of good toothpaste, and a lot of them are very low in abrasivity, so it would make me lead to believe that baking soda probably isn't as abrasive as we might think it is.
Okay. Is mouthwash beneficial as far as disinfecting? What should one look for in choosing a mouthwash?
Yeah, great question. So Kathleen is going to send you a pH list of all of the different mouthwashes. And what I look for in a mouthwash is one that doesn't have alcohol and one that has a high pH. A lot of these companies add alcohol into the mouthwash just to improve the shelf life. Listerine, for example, is a pH of 3. I would not use Listerine. There's one, it's by Act. I can't remember if it's restoring or anti-cavity, but it has a pH pretty close to 7. The one that I recommend for my patients is the treatment rinse from Carry Free because it also has the diluted bleach. And I think the diluted bleach does such a nice job with disinfection, both of cavities and for periodontal disease.
Then last question, by bleach, do you mean hydrogen peroxide?
Not hydrogen peroxide, but sodium hypochlorite.
Okay. All right. Well, thank you so much, man. That was a lot of great information. I learned a lot and took a lot of notes. I hope everybody else did too.
Uh,
Go
yeah,
for it.
this is me. This is my practice. The lower part has my email address. Please feel free to reach out to me. Um, thank you guys again for letting me come on this. I just want to be a knowledge base for Lawrence. So if you have questions, please don't hesitate to reach out.
Great. And the recording will be posted on the library's YouTube channel for retroactive. So you can go back if you forgot something or didn't take your notes, you can go back and um, rewatch this. Our next presentation for Gray Anatomy happens on July 15th, and we'll be talking about acupuncture with Jason Ham, who's with Blue Ginkgo Medicine. So something a little different for retroactive. We hope to see you there. So thank you so much, Dr. Van Boening. It was just excellent.
Thank you
And
guys very much for the opportunity. I appreciate it.
all right. And sounds like the thunderstorm's rolling in. So go enjoy the rain. Take care. Go. All right.